All right, good afternoon. Thank you for joining us for our October faculty development session. I'm Dr. Jessica Seaman, Academic Success Consultant for GME and co-chair of the Creighton Alliance Faculty Development Committee. Our committee strives to create and deliver effective sessions that develop our diverse faculty, which is you, as leaders in clinical care, medical education, and research excellence. Thank you for being here. Our presentation today is Mistreatment in the Clinical Learning Environment. What is it and what do we do about it? By Dr. Nicole Piemonte and Dr. Mike Epter. Just a few housekeeping items before I introduce our speakers and turn it over to them. We will record this session for future reference. We invite you to submit any questions in the chat, and our speakers will answer as many as possible at the end of today's session. There will be a short 4-question survey emailed to you along with the recording to help us in providing future sessions for you. So thank you in advance for providing any feedback to us. Also, this session is eligible for continuing education credit, and you will receive the website and activity code along with instructions in the email communication from Creighton Alliance. And we'll also share it in the chat towards the end of the presentation. If you don't want to wait for that email, then you can do it right away. So our 2 speakers today, Dr. Nicole Piemonte, she is the Assistant Dean for Student Affairs and a faculty member in the Department of Medical Humanities at Creighton University School of Medicine. At Creighton, she designed and leads the medical humanities curriculum in the School of Medicine. Her first book, Afflicted: How Vulnerability Can Heal Medical Education and Practice, was published in January 2018, while her second book, Death and Dying, was released just last month, September 2021. We're glad that she's here with us today. And Dr. Michael Epter is a professor and interim assistant dean of graduate medical education for Creighton University Arizona Health Education Alliance. He also serves as academic chair and program director of Creighton University School of Medicine Emergency Medicine Residency and vice chair of emergency medicine at Valley Wise Hospital in Phoenix. So very busy speakers that we have with us today, and we are so glad that they have been willing to share their wisdom with us today. So Dr. Piemonte, I believe you're going first. So if you're ready, I'll turn it over to you.
Thank you, Dr. Seaman. I appreciate that introduction. I'm so glad y'all are here today. As the Assistant Dean of Student Affairs, I deal a fair amount actually with student mistreatment, and I used to work a lot with the residents too, so have some experience on that side. If you have questions throughout this presentation, I have my eye on the chat, so I'm happy to answer those questions as I go through. If not, we can wait till the end until Dr. Epter is finished, and happy to have Q&A there, but I'll keep my eye on the chat for you also. Thank you again for being here. We're going to talk about what mistreatment really looks like in the clinical learning environment. So I always want to start off by saying that I acknowledge that you all, our clinical faculty, have a really difficult job. So where else but in medicine or healthcare, nursing, do you have to serve the needs of learners while also taking care of patients? So we're trying to develop you as an educator, but you're also trying to be a wonderful clinician. Sometimes I think it's a lot to ask. So I want to make it as easy as possible for you and always be a resource for you, but I do acknowledge that sometimes it feels overwhelming to be expected to be the best teacher you can be and the best clinician you could be. So I just want to put that out there. So what is mistreatment? According to the AAMC, so I know we've got other faculty on here that are not just medical education, but this is the Association of American Medical Colleges defines mistreatment as either intentional or unintentional. It occurs when behavior shows disrespect for the dignity of others and unreasonably interferes with the learning process. It's almost like you kind of know it when you see it. That's a kind of a vague definition, but that's where we are from the AAMC, but then they give us a little bit of examples. So Sexual harassment, obviously. Discrimination, harassment based on race, religion, ethnicity, gender, sexual orientation, humiliation. Psychological or physical punishment, I hope we would consider that mistreatment. And this one they added later. This wasn't until, I believe, 2011, they added using grading or other forms of assessment in a punitive manner. And I think it's important to kind of keep our eyes on that because our students are always so attuned to what's going to show up on my evaluation. And if they feel like threats of grades or this is going to appear on your evaluation, that can be considered mistreatment when used in a punitive manner. So we've got two kinds of mistreatment. We have overt mistreatment, and then we've got some of that more implicit mistreatment. But let's talk about overt mistreatment. This is what we can all kind of readily identify as mistreatment. So it's usually incident-based, like a singular event where maybe a resident treated a medical student poorly or an attending treated a resident poorly. And you can point to that one event. It's easily identifiable and usually easily reportable. When it's so obvious, it's reportable. So in the literature, I found an example. It seems a little bit hyperbolic, but it hopefully helps us all understand that this is mistreatment. So the example was, I filed a report because an attending grabbed and attempted to kiss me. The other unreported incidences consisted of being asked out and comments on how pretty and distracting the other surgeons thought I was. Okay, so yes, this is extreme. But the latter part of this, I have received many reports. This is mistreatment. This is incident-based, easily identifiable, easily reportable. So while this is an extreme example, sometimes it's not that extreme, and I do have to kind of attend to issues related to this. So this is both mistreatment and sexual harassment. So how often does this kind of overt mistreatment occur? According to the literature, and this probably aligns with my experience anecdotally, about 20 to 35% of students report being overtly mistreated in this way. Okay, not always sexual harassment, but something that they could point to and say that was mistreatment. So the AAMC has our students fill out a graduation questionnaire. All the fourth years have to, well, they are strongly encouraged to fill out a graduation questionnaire, and they're able to collect data from across the country on how many students are mistreated in this way. Granted, self-reported, but that's where we're at in terms of percentages. So the research and literature around mistreatment in medical education appeared in the early 1990s. So when it was, let's talk about medical students and their mistreatment, we didn't talk about it at all until the early 1990s, which some of you might have been in your training during that time. So around then, medical schools started implementing policies and procedures. They started doing faculty development around this because they realized or started acknowledging that this was an issue that they wanted to attend to. So Creighton University has their own policies related to this, just like every other medical school in the country. And so I want to share with you just a little bit about where Creighton stands on this. So the mission statement of Creighton is that Creighton exists for students and learning. So if you wanted to see the assuring positive learning environment, there's the link there. It is on the internet and available to you and in the handbook. But mistreatment and harassment of medical students, we consider it unprofessional, but also antithetical to the Creighton mission. Creighton is very student-oriented, so making sure we have policies around mistreatment, especially in the School of Medicine, is really important. So we say that any behaviors, actions, or expressions by faculty or staff that demean, degrade, harass, or threaten students is unacceptable, and these include, and I'm going to show you a laundry list. Be prepared. There it is. Okay, so some of these very obvious: inappropriate physical contact, physical attacks. Okay, physical, verbal threats, harassment, sexual harassment, discrimination, everything that we had talked about per the AAMC's definition is here, with the exception of written epithets, graffiti. But I want to focus on two in our little laundry list here. One is public belittling or humiliation, and the other being mandated performance of personal services. Okay, let's talk about the last one first. The reason I want to talk about this one is I didn't really think that this was an issue. Like, of course, you can't force the students to babysit your kids or run errands, okay? But why I want to talk about this is in talking to faculty, the conversations we were having were like, well, we do kind of give the students our credit card and like go to Starbucks and get us drinks. And there is this sense that maybe that's not actually appropriate because a student is not empowered ever to say no to that, right? They're going to go do that. So just think about it before you do that, because you think you're doing something nice, but asking yourself, would a student feel comfortable saying no? Probably not. My joke is always make the resident go do it, but you know, I don't really mean that. So the other thing I want to pay attention to here is this one more thing on this. This came up during COVID, this last point. And that was because the medical students came to me and they said, we got kicked out of the hospital for a while and our attendings and residents are working so hard. Can we offer to bring groceries to their house? Can we offer to watch their children? And my intuitive sense was like, yes, let's do that. But I talked to leadership, and the LCME, which accredits medical schools, is so particular on this point that we had to tell the students no, which is heartbreaking in a lot of ways, but they are so particular on it. So even if you were to pay one of our medical students to babysit, just our request is to not do that, because our accrediting bodies come down really hard on that, okay? Because there is a power differential in that relationship. So I just want to put that out there. So the public belittling or humiliation, we're going to talk more about that later, because, you know, the Socratic method, or sometimes we call that pimping, can be an effective learning strategy when done well. That's not what we're talking about here. Belittling and humiliation is different than asking your students questions to the point where they don't know the answer anymore, right? And sometimes that's a felt experience, like, you know, when it's going too far. But, you know, we've got in parentheses here, indicating inadequate preparation of assignments is not mistreatment unless done in an inappropriate manner. So if you were to say, hey, I wanted to prepare you, I told you to come with this learning issue done, and you didn't do it, that's not necessarily belittling unless there's some malintent behind that. So it's a little bit gray, but we'll talk more about that. Yes, Dr. Harder, I see you have a question in the chat.
So I have a question around that babysitting. About a couple of years ago, I had a fourth year, this was pre-COVID, I had a fourth year student who had actually requested, she had just sent me a text message saying, I would like to make some extra cash. And if there's any of your friends who would like babysitting, I'm open to that. It never worked out and I never gave her any contacts, but if it's a student approaching and if you're connecting them with someone who's not a Creighton faculty, is that appropriate, or should we just not get into it because of this gray area?
Thank you for asking that question. So, you know, the safe answer is just don't get into it. But if you were to connect her to a friend who has never been her attending, is never going to evaluate and grade her, has no power over her, but it's just someone that you're like, you know, they're outside of this world, they're outside of Creighton, and you could do that. I mean, that is, I don't want to be like quoted on this forever, but that would be acceptable to me. We just don't want to get students into a situation where someone who evaluates them is engaging with them at that level.
Sure, because she was very specific about the fact that she would like to do it for someone who's not within the Creighton campus. So yeah, but that answers my question.
Yes,
I would never get into it after this talk, but I'm just saying if that happens, I should,
No, that's a good question. Thanks, Dr. Harder. It's the same reason why we don't want students who could be evaluated by you all seeing you as a physician either, right? Seeing any of you as a physician. It's the same kind of principle there. So thank you for that question.
Oh, on that then, I've had a couple of students who have come through urgent care in our clinic. Is that not, and I was precepting the residents when that happened. So,
yeah, so in the future, you would just make sure that you have a different provider seeing them. So it is like really strict in the LCME that none of our faculty can see them as a provider.
Oh, okay. Well, that's good to know.
Good. I'm glad I was able to clarify that right now. So thank you for asking that question. Thank you. Okay, so I want to speak really quickly to sexual harassment, because this is actually handled by Title IX at Creighton. So it's a little bit separate, but it's part of mistreatment, right? So you've got quid pro quo, I'll do this for you if you do this, and then creating a hostile environment, which is what we saw in that first example about the surgeons making comments to that student. We've got a 72-page document on sexual harassment from Creighton. if you are interested at all, you can follow this link. And if you need to learn more about sexual harassment, so bottom line, don't do it. We have zero tolerance, especially our dean, Dr. Bo Dunley, zero tolerance. You will not be dating any of our students, nothing like that, zero tolerance. So just keep that in mind. Happy to talk more about that later if you would like. So sometimes the questions come up as what actions students can take if they feel like they're being mistreated. So per our policies, students could decide that they want to resolve the situation informally. I'm going to go talk to that attending and tell them they made me feel uncomfortable. That's a pretty courageous student, but they could do that. They don't have to formally report it if they didn't want to. They could handle the situation on their own. That doesn't happen a lot, or sometimes they'll come talk to me first and ask for some advice before they go talk to someone. But I don't know of many instances where they totally handle it on their own, but they could if they wanted to. The other option is putting it in a course evaluation or coming to talk to me or making a formal report. We encourage them to report to either me or Dr. Epter or whoever is in that role for Dean for GME to come talk to us and we'll help the student navigate that process. We also have a Dignity Health Confidential Compliance Hotline. If any of you are Dignity Health employees, it's on the back of your badge. They can call that number and make an anonymous report, and that will be filtered through Dignity's HR. They could scan a barcode at a clinical site. I'm going to have Dr. Epter talk a little bit more about this, and the report will come to the School of Medicine, and we can handle it that way. Or we've got this Creighton Help Someone reporting option. In Omaha, this is called Tell Someone. In Phoenix, we decided to do Help Someone. We advertise this to the students. They can anonymously fill out this report, or they could put their name in if they would like, and it will likely get filtered to me. It goes to Rosie McSweeney, who is part of our community standards. She's the director of our community standards and well-being, and she would get this report, and then she would pull me in as appropriate, or Dr. Epter, whom might need to be brought in on this instance. So our students are aware of this form. Faculty can also use this form too. This is the Help Someone. So like I said, students are encouraged to come to either me or Dr. Epter, and then we determine if it requires disclosure to other university offices like Title IX and civil rights compliance. So if this was an issue of gender discrimination, sexual harassment, racial discrimination, we'd have to bring in Title IX and the civil rights compliance office, but we would make that determination. And then we work to ensure complete confidentiality and anonymity for our students to protect them, our learners, our residents, and to protect them against retaliation. If an investigation of faculty is required, we would discuss this with the chair. So any of our academic chairs on this call, you'd get pulled in, or a designee if you thought someone else was more appropriate, within 10 days of the report. And then within 2 weeks, the chair or designee does their own investigation, talks to the faculty, talks to the residents, talks to the learners, and sees, what might have actually gone on. And then the chair or their designee will prepare a written report for me or for Dr. Epter. We would obviously probably have Dr. Richardson, Dr. Dunley looped in on all of this. And then the chair develops an action plan if they found that the faculty person had an issue. And then I would talk to the dean for med ed if this person was teaching faculty to see if we need to do something about their teaching responsibilities. And then I would meet with the learners to kind of let them know that we have been following through. We don't want to just leave the learners hanging, that their report went nowhere. And at the end of the academic year, myself, Dr. Epter, prepare a written report for the deans and to anyone else that we need to report to about unacceptable behavior that happened throughout the year. Okay, so long-winded, like we have a process. I just want you to know we have a process and we have policies. Oftentimes we're kind of navigating this with students and we don't necessarily have to go through this process, but we have process and we have policies. And I want to say that policies are helpful. But there's a caveat here about policies, because even though they exist, research shows that these policies aren't working very well. You can have policies in place, but does that actually change culture and actually attend to the issues that are at hand? So reports of mistreatment despite those, remember I said policies started being developed in the early 90s, reports of mistreatment have remained consistent for the past 25 years. We're not doing much with the implementation of these policies. The question becomes why? Okay. And you all know the answer to this. It's because mistreatment is gray. It can be endemic. It's just part of the culture, and that's hard to address. So many forms of mistreatment are subtle. So we call them environment-based mistreatment. It's just happening on a day-to-day basis. We've got systematic mistreatment. So these are repeated incidences that are happening all the time. They could be debatable. One person could say this is mistreatment and someone would be like, that's not mistreatment. That's just how we do this here. It could be hard for a student to report because they're like, it seemed like the faculty condoned what was happening, right? And then culturally embedded. It's just how it's done around here. This is the kind of mistreatment that's really, really hard to attend to. The problem is 90% of medical students report experiencing this type of mistreatment, and the most common being public humiliation. 90%, right? So we'll talk in a bit about whether it's because people aren't thick-skinned enough, okay? Because I know what some of you are thinking, but 90% of students report this. So the ironic thing is that policies can actually undermine efforts to eradicate subtle mistreatment. The policies might work to address overt, explicit mistreatment, but when it comes to subtle mistreatment, policies might be doing the opposite of what we want them to do. And that's because difficult to report events, those gray area events, they don't fall under typical treatment, physical threats, right? Racial slurs. If it doesn't fall in those categories, then a student's like, I don't know if I should even report this. So the policy makes them feel like they can't report it because it wasn't listed out in the policy. So this was from another research article that I found where they interviewed students. And the student here said, the difficulty is that on our own evaluation form, it asks, have you been mistreated? And our university has these definitions of what mistreatment is. But a lot of the times what I feel that I can't really say, okay, there's been one thing that makes me feel mistreated. Somehow I can't say that one person did something specific, but I feel that I'm working in an environment that is so detrimental to who I am and why I even wanted to go into medical school in the first place. So you all know what this student is talking about, right? Like just being part of that culture. And it might be just like a microcosm within that culture, but you can't put your finger on being mistreated. And so a student might not ever report it, but they do feel as though they've been mistreated. So this subtle environment-based mistreatment is actually more distressing to students and to residents than if they were overtly mistreated. That one-time incident-based awful experience, they'd rather have that than to feel kind of demoralized every single day. So that's because we've got a hidden curriculum of professionalism, right? You might have heard me talk about the hidden curriculum before. This article by Bernard and Brislin was written in 2007 when they were medical students. Now they're physicians, but they wrote this article that talked about this hidden curriculum, right? And the hidden curriculum, just so you know, is when our explicit curriculum, which is things like compassion, empathy, respect for others, respect for patients. That's our explicit curriculum. That's what we say. And then they get on the wards and they're like, oh, wait, that's not what I learned about. We actually do these things. That's the hidden curriculum. And the hidden curriculum is more transformative for students, for better or worse, than the explicit curriculum. It can change who they are at a core level, more so than any kind of like learning activity I do with them in first and second year. So Bernard and Brislin say, students struggle profoundly to understand the disconnect between the explicit professional values they're taught, altruism, respect, honesty, and the implicit values of the hidden curriculum, or what really goes on. They said, our observations show that students become professional and ethical chameleons because it is the only way to navigate the minefield of an unprofessional medical school or hospital culture. So I am not saying this is necessarily the culture our students are in. You guys are doing such an amazing job with our students. And they've got incredible clinical mentors in you where you guys are cultivating them in the way that we want. But there are areas in the hospital where it's not that way. And so students learn how to be a chameleon and turn into whatever this team thinks is professional, which might be different than this team, what they consider professional. And so they're kind of morphing all of the time and not grounded in their like core identity. So all of this can dissuade people from talking about what they experience because it's so disorienting. They experience disparate things at different times. So what are the effects of mistreatment? Some of you know what the literature says about this, but we've got decreased self-confidence. This is among medical students, substance abuse, depression, thoughts of dropping out of medical school, regrets for choosing medicine as a profession, right? That they wish they never did this. And then when it comes to residents, this came out in Academic Medicine in 2017. The leading cause of death for male residents is suicide. Higher rates of suicidal ideation earlier in training. So in the first and third quarter, and in the first and third quarter of intern year, we've got an increase in suicidal ideation. It increased 370% during the first 3 months of intern year. Okay, it's a really difficult transition for our interns, and the literature is not encouraging in that regard. Okay, so for some of us, we need to talk about this. Is it really that bad, right? And you know, you've all been through this training and the training was really difficult, but is it really that bad? So some things that I sometimes hear are today's students and residents, especially millennials, are too sensitive and misperceive events as mistreatment. Okay, I understand the point, but let's think through this a little bit. So reports of mistreatment have remained consistent for over 20 years, okay? Whether you're a millennial or Gen X or Gen Y or baby boomer, I don't know, 20 years, mistreatment has remained consistent. It's not that we saw this incredible increase when the millennials entered the healthcare space. That's not what happened. It's consistent. Medical students actually perceive events the same way attendings, residents, and nurses perceive them. So this was a study where they interviewed people after moments of mistreatment, and medical students agreed with the nurses and attendings and residents by saying, no, that wasn't mistreatment, or yes, that was. They agreed. Yet faculty continue to underestimate how often the events occur, especially in the training of residents. So even though they'll both agree what is mistreatment and what isn't, faculty underestimate how often this is happening. Something else you might hear is public humiliation is an effective teaching strategy. I have heard this before, right? So, you know, you'll remember what's yelled at you kind of thing. I really think, having done other things in my life, I really think it's only in medicine and maybe law that public humiliation is seen as a teaching strategy. It is not natural, is what I'm saying. Okay, it feels natural, but it's not natural. There's a fine line between the Socratic method or pimping and public humiliation. Okay, it is a fine line. I think the Socratic method is helpful, but we don't want to tiptoe over to public humiliation. Here's a picture of Socrates I found, and he's befuddled as to why his Socratic method got perverted into public humiliation. It was not intended to be that way, right? So this is endemic to the culture of medicine, this public humiliation. And so sometimes we don't realize how abnormal that is. So many attendings, residents, and even students believe that public chastisement and intimidating behavior is just redirection and the natural socialization of a doctor. Okay, so I'm here to tell you that that's strange. It shouldn't be that way. No other field really kind of cultivates their future healers in the same way that we see in medicine. And then research shows that 64% of students are humiliated by faculty and 76% humiliated by residents when they interview medical students. Okay, you also might hear mistreatment is a rite of passage. So there's common beliefs about mistreatment building resiliency. You remember what was yelled at you, and we're going to make you more resilient for when things go down and when things get difficult. And research shows that traumatic events like the death of a patient, a code, witnessing suffering can build resiliency, but public humiliation does not. It has the opposite effect. The majority of students who feel humiliated start to avoid those interactions. They start to avoid personal interactions with you and personal interactions with others if they felt humiliated. 15 to 30% consider quitting medicine or say they never would have gone to medical school in the first place had they known it was going to be like this. And this one is very frightening to me right here. One study directly correlates feeling mistreated to students reporting they then mistreated patients. This misdirected mistreatment to patients. Patients are all that matters. And if being humiliated makes a student mistreat a patient, we've got to change something. Problem is, change is really difficult. There's a transgenerational legacy that I was trained this way, so I'm going to train you this way. Right? We see transgenerational trauma or generational trauma in families, right? And that's kind of what's going on in the culture of medicine. We're just passing it down from one person to the next. Hospital culture, mistreatment's a staff-wide problem. This is not just among nurses, it's not just among docs, like this is a staff-wide problem and that's hard to address. Residents, faculty, and staff need to feel valued and supported. And the disappointing thing is that a longitudinal study of 13 years of interventions, establishing committees and reporting protocols and doing faculty development had very little effect on the number of students who reported mistreatment. 13 years of an intentional interaction. So interventions at the level of the formal curriculum, creating policies, right, have very little effect on culture. So what can we do? How do we change culture? I want to return to our millennials for a second, because a lot of our residents and medical students are millennials. They won't be for long, but they are currently. So millennials desire authenticity in all areas of their lives. So this is why we're like, oh gosh, you know, that millennial is a slacker. They leave work early. From my view, and in some of the reading I've done, a millennial is like, I want to be an authentic doctor and resident, but I also want to be like an authentic partner and dad, right? So like, I'm going to show up at home and show up at work. And so sometimes it means leaving work to want to be present as a father. I think that's what's going on with our millennials. And just a little aside here, because it resonates with me. The next time somebody complains about millennials, maybe remind them which generation linoleumed over all those beautiful hardwood floors. Okay? As a person who owns a home from 1930 that had a bathroom with linoleum that I had to rip up and had beautiful hardwood floors under there, I was like, who did this? A millennial would never do that, okay? So let's not give them such a bad rap. They didn't linoleum over floors. Okay, so when mistreated, a millennial learner can easily lose sight of what makes medicine authentic and meaningful. They start going, why am I doing this? I'm being mistreated. I don't feel valued. I don't feel seen. This doesn't feel like authentic work. Why am I doing this? So it's important that we ensure that that's the kind of environment, an authentic environment that they're working in. So people need to feel like they're active participants in their training. And studies have shown that students and residents, obviously, who feel involved, empowered, like they're part of the team. What's interesting here is they often react more positively to events that another person might call mistreatment. If a student feels like they're actively part of the team and someone mistreats them, and maybe nursing faculty walks by and like, oh, that student's getting mistreated, that student is more likely to say, no, I wasn't. No, I wasn't. They have high expectations of me because I'm a member of the team and patients' lives are at stake. So engaging in meaningful work. Most medical students agree their best moments in med school were when they were contributing and doing work that mattered to them. And I want to say hierarchy in medical education is not the problem. We need hierarchy. We do need to know who's in charge. That's not the problem. But people do a better job when they're brought into the team environment and feel like they matter. So ways you can do this, clearly articulate expectations for the rotation, clearly. I know sometimes we think we do, and then students would say that there were no expectations. Clear expectations can make them feel like they're really part of the team. This is what we're doing today. This is what's expected of you. Helping interns and students feel like they're part of the clinical team by involving them. How can you do this? Very briefly share how you teach. If you use the Socratic method, tell them. I'm going to ask you questions till you don't know the answer anymore because that's how I teach. And then these transparency about these goals, like I'm pushing you because I want you to be the best physician you can be. I'm going to ask you questions till you don't know so that I can help you. And I know what you don't know. Just be explicit about it. Say it out loud. And this can change the tone for the student's experience entirely. So I'm going to leave you with this. This is not about being nice. I don't want to be mistaken as I'm just saying, can you start being nice to people? This is not about being nice. Sorry that this is a little bit blurry, but what this is about is having high expectations, but keeping a psychologically safe environment, okay? So if you look at this, we've got, if we have low accountability, that you don't really have any expectations of your learners, and high psychological safety, they feel great on that team, no one's mean. They're in a comfort zone. You're not pushing them. They're not learning. We don't want that. If we've got low accountability, they're not really expected to do much, but low psychological safety, they're also treated badly. They have the apathy zone. They're going to check out. I don't contribute to the team. They don't expect me to do anything. And they treat me like a child. They're apathetic. They are disengaged in that rotation. And we don't want them there either. You could have high accountability, high expectations. You are going to do this for your patients. You're going to do this for the team. But if psychological safety is low, because they're also getting yelled at and being mistreated, they're in the anxiety zone. They might work hard, but they're scared of you and they're not retaining what they're learning because their cortisol levels are through the roof, right? So where we want to be is the learning zone. Really high expectations and also high psychological safety. There's a focus on collaboration, learning in the service of high performance. And then the hospitals described in this article, so if I will send you guys this article, the learning zone is where they were. I see someone with a hand raised. I am happy to answer your question.
Hi, this is Surabhi Amara. I'm one of the medical oncologists at Valley Wise. So I just have a comment, I mean, I always try to be nice to students and I don't think anybody will ever say that I've yelled at them. But I think these are sort of little bit of it is unrealistic expectations. Like you're saying, they want to be home. I get that. I also want to be home. I don't want to be at work. But there's somehow like medicine is just very demanding. They're just still learning. So it takes them longer to do stuff. So we can't ask them questions because it upsets them. We have to let them go home early because they have to be a good dad at home. And like if we try to educate them, I'm not talking about yelling. I've had medical students tell me, I was trying to teach him, like a patient came with CML and had a big spleen. And I was like, oh, like, can I teach you how to palpate it? Mm-hmm. And he's like, why do I need to palpate the spleen? I'll just order an ultrasound. So people don't really want to learn. And it's sort of like putting unrealistic expectations on faculty to think like it's possible when patients are crashing to let them go home. So if you give them responsibility, they'll have to stick around if the patient is sick. So they don't want to do that, but they want to have responsibility, but everybody has to be nice to them. We can't ask them anything. If we try to teach them something. So it was just me, him, and the patient, and I didn't yell at him, but I was really upset. Mm-hmm. I was like, how will you know if the patient comes to you? He's not going to tell you he has a big spleen. I just incidentally found this guy's spleen, right? So now I'm going to investigate. But if you never feel it, how will you even know to order anything? So I think their expectations need to be readjusted too.
For sure. So thank you so much for that comment. I think that's exactly what we're talking about here. I think accountability needs to be high. And it should be like, no, you are going to lay hands on this patient and palpate their spleen. No doubt, right? Accountability and expectations should be very high. And they shouldn't be like, oh, you're good to go home early, all of that. It just needs to be in a psychologically safe environment where you say, I needed you. I'm upset that you didn't want to palpate that person's spleen because I'm trying to help you become the best doctor you can be. And these are our expectations. So that's why I do want to reiterate that this is not about being nice. We can be firm. We can hold people accountable, but we can also tell them you're learning, you're going to make mistakes. You're a novice and I'm here to guide you. And I think about being very explicit that that's your intention. You can then create this environment, right, where it's possible to give tough feedback, that requires trust and respect without tiptoeing around the truth. So they have to feel safe enough that they trust you and see that you are credible. And then you can give them really tough feedback and have really high expectations and say, this matters because patients matter. So I hope I don't get misperceived as saying, let's just be nice to everyone. It's just about helping them not feel belittled while also having high accountability. And Dr. Harder, I see that you have a comment. I'm going to finish this up real quick and hand it over to Dr. Epter, and then we'll get to the Q&A. So we've got a little bit of time because I think some of what Dr. Epter is going to talk about might address some of your questions. So just to wrap it up, right? Mistreatment's pervasive, it's often subtle, and it's culturally embedded. Policies are good, but they are insufficient. They are necessary, but insufficient because they're not addressing the core issues. Our learners need to feel valued, so expectations should be clear, and they should feel like they're contributing to the team, but we should still have very high expectations of them. No doubt about that, high expectations. So more than being nice, we should create context with high accountability, high psychological safety, where people are allowed to make safe mistakes. And addressing mistreatment is harder than it seems, but I think it's possible when we start from an assumption of virtue. Let's just start with like, I'm gonna assume this medical student wants to be here, wants to be a good doctor. If I can start from that assumption, then we might be able to move forward to create psychological safety. So Dr. Epter, I'm going to hand this over to you so you have enough time, and then happy to answer people's questions after Dr. Epter is finished. Thank you all.
Thank you. I appreciate it. Great presentation. Since we're almost at 1:45, I'm going to see how I can manufacture this to kind of get through some of the main points here. So I'll skip around a little bit and kind of work from there because I have a few videos that may be helpful for people. So does everyone see success on their screen? Is anybody going to give me a thumbs up so I at least know we're there? Okay, good. So what I'd ask you to do basically is, obviously the phone becomes kind of the major notepad for folks these days, but the old pen and pencil work just as well. While I show you this video, perhaps you can just jot down and do kind of a little bit of mental stimulus as to what are the 3 most important characteristics of what you deem an ideal teacher. And I'm sure many of you already actually have these and many others, but I think it's important to kind of go through this mental exercise, and then it makes it much easier to recognize when you're not performing at your best or that the environment just doesn't precipitate that. The next thing is obviously to look at what are the 3 least desirable characteristics of teachers. So we all know through our training and when we've seen this, that it's like, wow, that's just not how I would approach that scenario. Perhaps they can, and this is a great opportunity for faculty development too. So think about this, the 3 most desirable, the 3 least desirable. Obviously, if we were together, had a little bit more time in kind of a workshop format, we'd actually discuss this amongst ourselves. Feel free to put it in chat if you'd like, and then I'll show you what the literature actually shows. So while that's happening, I'll show you this video just in an effort to lighten the mood, if you will.
Good morning, Sir Lancelot. Good morning. Morning, gentlemen. Good morning, sir. Not late, I hope? Not at all, sir. Come along, my man. You must pursue me. You must pursue me. I suppose you got another half-dozen boring cholecystectomies today? Yes, sir. After last night, I feel like one myself. How about that gastrectomy I did yesterday? Not so well, sir. Oh, pity. Great pity. Morning, sister.
Morning, Sir Lancelot.
Everything ready?
All ready, sir.
Splendid. Now, you just lie still, old fellow. I'm just going to discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked? Yes, sir. See anything? No, sir. Very good. Carry on. Gently, man, gently. You're not making bread. Don't forget, to be a successful surgeon, you need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it? Yes, sir. Well, what is it? A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? Don't worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. Where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. I don't buy this. Has nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find?
Subcutaneous fat, sir.
Quite right. And then we come across the surgeon's worst enemy, which is what? Speak up, man. Blood, you numbskull. You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time?
10 past 10, sir.
All right. So hopefully you came up with a couple of things as we were watching that. And I want to...
The perfect podcast is out there. And with over 2 million of today's most talked about podcasts available, Spotify is the best place to find the one you love. Whatever you're into, get way more into it with a podcast. Find the one you've been listening.
All right. Sorry. So I'm going to show you now some of the things that I want you to think about from your own stuff. This online clinical teaching perception inventory has been used for over 25 years for faculty development and also for assessing comfort in clinical teaching. And basically what the authors did was to look for feedback on discrepancies between what an ideal teacher is like and what self is. So they basically took about 500 residents and faculty and identified top descriptors for ideal clinical teachers. And this was then followed by a wonderful article by Massanuga, who looked at 1,523 residents and 737 faculty members and ranked 28 single word descriptors that characterize clinical teachers along a 7-point scale. And we're gonna take a look at those results after we go to some great videos that come out of Stanford to look at the clinical learning environment. So let me share this screen. One moment. Okay, and hopefully you see this. And we'll dialogue this in a moment.
Hey, Malcolm, what you got?
Mrs. Myers is a 65-year-old female, post-op day 1 for status post-laparoscopic ventral hernia repair. Overnight, she spiked her fever at 39.0. She also had 1 episode of emesis this morning with some abdominal pain. Her vitals were 39.1, where her Tmax and her heart rate was between the 90s and 110s, with systolics of 100s to 130s. Her respiratory rate was 22, but she was sitting well in room air. In terms of her ends, she took 1.2 in and 1.4 out with 500 cc's of emesis. On exam this morning, I noticed some moderate abdominal pain with some diffuse guarding, but her incisions were clean, dry, and intact.
So you said she had a temperature of 39.1. So what would be on your differential for like post-op fever?
For post-op fever, leading the differential would be atelectasis, okay. But she could also have post-op pneumonia, a UTI, possibly a wound infection, maybe a drug reaction.
Kara, what do you think about that, especially in light of Ms. Myers?
Well, I'm concerned she could have a mistenterotomy. She's tachypnic, tachycardic, had emesis, and I'm concerned about her abdominal exam. She's diffusely tender.
So Malcolm, you were in the operation. What did y'all do?
We performed lysis of adhesions with a laparoscopic ventral hernia repair with mesh.
Okay, well, Kara, was the adhesiolysis pretty extensive?
It was pretty extensive, and there was bowel in the adhesions, but we thought that we were well away from the bowel cirrhosa.
Okay, well, Malcolm, why don't you go ahead and get the labs and then join us back in the room and we'll do the exam together.
Sounds good.
All right.
All right, let's look at these labs. Well, that was kind of stressful to present for the first time to my attending. I hope you liked it. Then again, I did learn a lot about the differential diagnosis for fever. I'll keep that with me as I go forward.
So my question for the group is, do you think this was mistreatment? Why? Why not? Anyone want to jump in on that? Shane, you said no. Do you want to elaborate? I know I'm putting you on the spot, Shane, but you know I love you, so help me out.
Okay, so the attending was, when he asked questions, the tone was good, right? So you know, you can communicate a lot in tone. And then he seemed very responsive. I felt like he was watching their voices and expressions to see how they were responding to his questions, and that he didn't pimp them to the point where they were clearly embarrassed, right? And there was this real collegial, collaborative feel to it. And there was a sense that they were a team, and they made a plan to go and do things together, and they each had their role to play. And so what he did is very similar to what in psychiatry we call authoritative parenting, where it's a high level of expectation combined with a high level of responsiveness.
Okay, wonderful. Let's see, in the chat, we have folks agree. So does anyone see this as that it was mistreatment? Because I agree with Shane. Most things within were done, I think, really well. There's a couple of things that I'm going to point out as we kind of work through this, because the whole goal for me is to kind of give you some solutions about creating this positive learner environment. You know, Dr. Piemonte did an incredible job of going over Creighton policies, which are essentially the same for all residents as they are for students within Creighton, and then mistreatment itself. So the goal is to kind of get you to, hey, well, how do you create a positive clinical learning environment? So the only thing I would add in terms of some of this with the order of questions should really start with the junior level learner and then run up to the senior level learner. Because if senior level learners are asked first and they don't give the correct answer, that can obviously create somewhat of a negative work environment, or that the junior level learner may not trust the senior learner. Who obviously they're going to emulate with certain things, because the residents' teaching of students is so paramount. The other thing, there was no introduction to, in this case, obviously it's simulation, but you saw that in the Sir Lancelot video. The patient was never involved, and the clinical learning environment should start and end really with the patient as the center. So think about that as you know, we kind of roll forward. So I'm going to show you another video here. And then this one is going to become a little bit more obvious for folks, and hopefully that'll stimulate respective conversation.
So Mr. Rudd is a 54-year-old male, post-op day 2, status post grand patch repair for a perforated gastric ulcer. No acute events overnight.
All right, stop right there. Let's see if you know what the hell you're talking about, okay?
Yeah, thanks for that. It kind of sucked on rounds this morning. You can spare us the pain this time.
Why don't you tell me exactly what you think a grand patch repair is?
Well, I'm not quite sure, but I think it's when you put part of the greater omentum over the perforated ulcer.
You don't know exactly? This is your patient and you don't know exactly what that is? Can you tell me what the 2 primary causes of the gastric ulcer are?
That would be NSAID use and H. pylori bacteria.
Well, any idiot knows that. Why don't you tell me something for real? What do you do every time you see a perforated gastric ulcer? Let's go, come on. You know the answer, let's go.
Not really.
You biopsy it, you idiot, you biopsy it, all right? Here's a question even an undergrad would know. What cells make acid in the stomach?
Oh, that would be the parietal cells, sir.
All right, I've heard enough. Why don't you stay here, think about the answers, let's go around, all right?
I don't understand. I thought I answered some of those questions right. I feel totally disrespected. I didn't even get to finish my presentation.
So this one obviously much more obvious in terms of what's gone on here, but how about folks in terms of constructive versus negative feedback. How would you might provide that herein in this case? Anyone like to take a stab at that? So basically some thoughts here is, you know, obviously there was mistreatment in multiple different pathways within this case study. And even if you look at the other residents, the resident was on the cell phone, they weren't engaged. The intern rolled their eyes, attending rolled their eyes, the any idiots know that, etc. So there was a lot to be desired in this case. But the question is, well, how do you set this environment up better? So that's what I'm going to go into herein. The first thing to know about, which Dr. Piemonte talked about, was that for residents and students, there is this barcode that does exist in different clinical treatment areas, or will be in certain ones within both institutions, for any issues concerning mistreatment, unprofessionalism, or unethical behavior. And what it looks like is pretty simple. This is, you know, have you been mistreated? Who was involved? Did you report the incident? And then what type of behavior was it? So it's basically residents will scan, or the student will scan this barcode, this Google sheet then pops up, they populate it, and then it's sent to me. And then if it's a student issue, it goes to folks within the School of Medicine. If it's a resident one, it's kept within, unless it happens to be my own, then it's a conflict of interest. And we try to obviously solve this. So realize that that is out there for the reporting piece. Now, if you go back to the good teacher and some of the things that you might have listed as part of your things that define great teachers, based upon the clinical teaching inventory, here they were: encouraging, stimulating, competent, communicates well, well-read and organized. And I'm sure many of you have those similar characteristics, versus those that scored pretty poor when those learners and faculty were assessed, were corrective, conventional, cautious, and controlling, some of which you saw in that previous second video. So my thought in terms of how to bring this together for you is to think about what I deem the Epter 5 Ps, which is proper preparation prevents poor performance. And that first begins with assessment of your clinical learning team. And then these are some questions, and this will be in the notes and what have you, because it's a lot to digest. And great for workshop formatting and to brainstorm as a group. But these are some of the things that I try to surmise when on shift with a group of students and residents. What's the learning style? And then in terms of the kinesthetic tasks of a resident, if they're performing a procedure, what is their skill set? I think the question of what challenges have you faced on rotations, blocks, and how did you overcome them is good for your clerkship director to probably sit down with a respective student who's coming on the team, and then kind of report back to your faculty so you can teach the gap, if you will. But asking students and residents right off the bat, what do you want to accomplish today, has always been something that I really focus in, because then I can teach exactly to what potentially is being looked for, while also trying to meet my own goals of teaching during that shift. And then in terms of creating the learning culture and challenging, which I think, one of our previous physicians brought up, the medical oncology specialist, this is these two pieces. So rules of engagement. For both UME and GME learners, their learning and work environment are intertwined and inseparable. I don't look at, well, this is the student and this is the resident, right? They're looked at as one. Number two, for rules of engagement, the patient is the epicenter. So involving the patient is really key, but also identifying the roles of both yourself and the team is similarly key. And then in a continuous learning and improvement health system, every participant is both a learner and a teacher. And that's really been put forth in the literature at this point. So I'm going to skip through these because we don't have the time to take a look at those. But some deadly teaching sins: interpreting versus describing. For me, I will usually ask residents and students especially to interpret rather than, to describe what they found rather than interpret. Because to me, the description gets to the heart as to whether or not they have a good depth of knowledge, as well as can, think about the patient exam or history to formulate a differential diagnosis. The interpretation piece sometimes can be a miscalculation. So oftentimes I'll lend towards the description versus the interpretation. I talked about questioning upper level learners first, because if wrong, credibility is probably lost when the junior level learners see that, or if the student trumps the senior level or chief resident in the clinical learning environment, I think that becomes a little bit challenging. Next, define roles and responsibilities. We certainly don't have to teach everything as faculty, but creating that safe environment is key, and also making the patient part of the teaching, and also being able to describe things to the respective learner, I think has great value. Next, engage the learner. There's tons of ways to do this. I can attach different, if you will, articles that have gone over these, but think about these used in your presentation, in your learning environment with the students and residents, and I think they do quite well. Facilitate the learning. Remember that teaching has value only to the extent that it facilitates learning. And then one of the things that was not present in that first video was the giving of feedback to the respective student, which is all part of the learning environment. So summarizing and self-reflecting allows for closure of that teacher-learner interaction. So that's really important. And really also this multi-directional feedback as well, for us as faculty in teaching students and residents is equally as important. Certainly as you have fun, but then summarize and self-reflect with the team is the other key piece. So there's a lot here. Unfortunately, we're limited on time, but I'm going to give you certain articles that you can take a look at, as well as a wonderful article that was put forth in the internal medicine literature about how to improve, or if you will, enhance the clinical learning environment. And I can attach that as well. So I'll leave it for the questions at the moment, even though there's a couple of slides remaining, but the questions I think are equally as important to get out.
Dr. Harder.
So I have a general question. This is actually Dr. Surabhi's comment about that, the example she gave. So I feel, and this is not generalizing all the students, but you know how much I am into physician wellness. And I feel like there is a little bit of confusion, and I will not mention this generation versus others, but there's a confusion between maintaining work-life balance and still staying accountable for patient care. And my question is, do we have workshops for students or sessions like these where we sort of address that with them, just kind of giving them an idea about what is wellness? If you have to attend to your family, which is just as important, but if you have a patient who's coding, it's okay to wait a little longer until you finish your clinical responsibilities before you drop something and leave. So I struggle with that lately as well. So I'm just wondering.
Thank you, Dr. Harder, for that question. So we do throughout the 4 years, we've got personal and professional development and leadership training where we kind of address these things. Now, it's been my experience, you all, that it is usually the exception, not the rule, that I've got a student who's making up things to try to get out of work. It's just that we remember those because it feels so problematic, because you all are giving so much that when you've got a student who's just trying to, just fall through the cracks and not be noticed or actively get out of work, it's so frustrating. For the most part, the students I'm working with might have serious problems going on. And I'm like begging them to try to take a day to go attend to what's going on. That's been my experience, but that doesn't change the fact that there are some trying to get out of it. And those are very frustrating students. And please know that on our end and the mentors that we have for them, I have the highest expectations that they are going to be there, show up, work hard, and stay longer if it means that's going to serve patients. That is our expectations always. So Dr. Harder, I mean, I would love to work with you on some of those things as well, because those are the expectations for our students.
I would love to, because I have some ideas about that, so we can talk about it afterwards. One more question, Nicole, on microaggressions. If we have any sort of workshop or any educational activity, even addressing what those are, like what defines a microaggression and how do you recognize, how do you address? I think it's important for faculty, students, residents at all levels.
We can do more work in that area. So they study implicit, like we talked about implicit bias and aggressions and them and kind of in that context of racial discrimination. But we do need to do some more work around that. And even maybe the women in medicine and women in surgery group, we could do some work on that as well. I think that would be really important.
And Nicole, we do have microaggressions in medicine from Ron Brown that is coming up. That will be going out to our faculty as one of our faculty development sessions here in the next few months. So thank you for bringing that up, Dr. Harder.
Thank you, Jessica.
Thank you.
All right, thanks, Dr. Harder. Dr. Vail.
So to address a few things that both you and Dr. Epter said, as well as Dr. Harder's question, one of the things that we implore to the students and residents in our program, you got to stop thinking about work-life balance, because the example you gave is a perfect example of why it leads to frustration. If you look at the definition of balance, no one in their life can balance everything, because equilibrium must be maintained. It must. There is no option but to maintain equilibrium. Therefore, if you get something, you got to give up something. There is no voluntary part of that. Whereas if you make it a priority system instead of balance system, the priorities then become more logical and favorable, because the resident or student is helping to make the decision of what is that priority. If their priority is to get home every day at 3 o'clock, they will never be successful. That's their priority, and medicine takes a back seat. So the learner's possibility, potential, better word, is then compromised because they chose the priorities. We did not. Our priority is teaching. Our priority mandates patient care. And I believe if the philosophy and the culture to a priority model instead of a balance model, students and residents would be happier and gain favorable status amongst faculty trying to teach them, because we understand where they want to be when they want to be there. Versus, unfortunately, even Creighton is still one of the schools that promotes balance. And I highly disagree with that.
Dr. Epter, do you want to have anything to say about that?
Actually, Dr. Comp, Jeff does tremendous work with our wellness and resilience champion stuff. And he wrote something in chat box, which I think is fantastic in terms of integration. So Jeff, are you there?
Yeah, I mean, Dr. Vail, I agree with you. I dislike the term work-life balance, but just because of the wording, I think in spirit, it's there. It needs to be just an integration of how you prioritize, right? How do you integrate your work with your life? How do you prioritize your patient care? And I think, to be just a little bit, I guess, on the other side, I think it's also our job to show how we have the best job in the world and why we want to stay late to take care of our critical patients, why we want to be the ones that learn how to perform a proper in-depth physical exam, and really showing and being able to say, hey, we do this because we take care of patients, and we take a lot of pride, and we take that pride home with us. So I think changing maybe some of the script of how we teach and how we bring that, and how we lead by example and model, I think is very, very important, especially when we have an incredible opportunity like this to be able to talk with other education leaders that are kind of struggling with some episodes of, I guess, student motivation and sometimes resident motivation too. So identifying the, if there is, just like Dr. Piemonte was saying, if there is something else going on outside of what's happening on shift today, asking and identifying and seeing how we can help with that. But I agree. I think that it's changing the script a little bit and recognizing and telling people that it's really not a balance, because you're absolutely right, because you have to push one thing off the edge to have the ability to put all your effort with the patient you have in front of you, but learning how we can do multiple things and allow for that sort of shift.
Yeah, Dr. Comp, thank you so much for that. So Dr. Gillespie, Tom Gillespie talks about this too, work-life integration, that there really isn't a balance. So that means you kind of bring your whole self to work and you kind of bring work home with you. And so can we rethink work-life balance where Tom's example is like, well, could we have computer networks that are safe enough that I could do my online banking at work when I've got 5 minutes? Because it's not that I work at work and then I do my life at home. They're all bleeding together. And can we rethink organizational structures that allow us to be whole people? And with the medical students, that means, you know what, if they want to come to my office and talk about how they're going through a terrible breakup, like I'm here for that, because they're a whole person and it's just inevitable. And it's not a split between my personal and professional self. I'm just myself. And I think we need to create spaces where that's okay and people can be whole people.
Also, Nicole, often wellness is taught as something that happens outside of work. And I think we spend a lot of time at work. So we have to figure out what is wellness at work as well. And one of them is gratification with what we do. Like it is a privilege to work with patients and take care of them, right? And to have a good supportive wellness atmosphere at work is just as important. So we have to also demonstrate and teach residents and students that we have to see work as a way to keep ourselves well, which means healthy environments. So I think that I like the whole work-life integration that Jeff just mentioned, but I think that's important to demonstrate, because what this is leading is when they become attendings, there'll be frustrations about not able to leave at a certain time. And because that's not how attendings' lives are. We don't live like that, right? So it is preparing them for what the actual life in medicine is and not the 80-hour rule. I mean, we maintain those rules, but I hope you get my point.
Absolutely. Absolutely. And I think it is contingent on us. That when you have those frustrating moments with students who, like I see in the chat box, like they weren't prepared for that 5-minute talk or whatever it might be, I think it is contingent on us to mentor and model. So Dr. Harder, what you're talking about right now, you embodying that as well. And then having hard conversations to say with students, I asked you to prepare a 5-minute talk and you didn't. And this is what that communicates to me. It communicates to me that, you're not taking this seriously. And this is the most serious and most amazing job on the planet. And I think we need to just have the courage to kind of have those conversations instead of getting merely frustrated. I think it's so easy for us to get merely frustrated and stop there. And I think it should propel us to just start having those really mentor-mentee conversations, because that's what's part of being a clinical educator.
And I think for faculty also, being compassionate does not equal letting them off the hook. Holding them accountable is also being compassionate towards their training. I think it's teaching them right values and ethics.
Totally. Could not agree more. Jessica, you're unmuting yourself. You're going to kick us off because we are way over time.
I'm so excited. There's been so much conversation around this topic. I mean, it obviously was a great one for us to present. And thank you so much to Nicole and to Mike for your willingness to share your time and your thoughts and your examples. And thank you to all the participants and those that wrote in the chat and asked questions, because that's what really led to the great conversation. So we are going to make sure that we have those articles you mentioned, that those are going to go out with the slide presentation and the recording and the survey and the CE tracker if you weren't able to get it here on this chat. Where I put those links, we will make sure that that goes out to our distribution list. So thank you so much for joining us, and be well.
Thank you. Thank you all for being here.